Today I'll be talking about this the next step that we've thought that stepwise approach with gas or gas plus TPA. If it is huge or some indications, we have to think of subretinal TPA and with or without gas. That's the thing. So the main inventory when you plan to decide to do subretinal TPA, what are the things that you need apart from the drug is that subretinal cannula. This is one thing that you need to keep it handy, that whatever one odd case that you get once in a year, or there are expanding indications for subretinal cannula, 38 gauge or 40 gauge attached to 23 gauge or 25 gauge trocar, whichever is the favorite one that you're using. The other one is a microdose injector, but you can as well, when we are injecting a drug, most of the times there is no, we cannot find another patient who will require a TPA. So you mix the entire drug, you can attach to a 10 ml syringe the entire drug or whatever little, and use this cannula and use for that one patient, and use the visco VFI injector from Constellation and then inject the drug. So 10 ml syringe. So basically you need the 38 or 40 gauge cannula from Med1 is what that we need to use. Now, when we decide to do when you give an injection, what are the parameters that we need to keep for while giving? Ideally, you try to keep the IOP slightly low, or around 10 millimeters of mercury, so that if you keep the IOP high, then you find it difficult to inject the drug to the subretinal space. The other thing is how much is the injection pressure that you plan to do. This has not been studied in submacular hemorrhage injections, but various studies where subretinal gene therapy is being given, enough literature is there where they show that the roughly the 5 to 8 psi is what that pressure is required to inject drug subretinally, and also initially for the creation of the first bleb of drug that comes subretinally, you slightly require more pressure, whereas once the bleb is created, to propagate even slight lesser pressure. So 5 to 8 is for a bleb initiation, and then 4 to 7 will be for bleb propagation. So, and one more thing, because in this kind of, because we don't have access to intraoperative OCT, we all have depend on our ability to see through and to exact the location of the tip of the cannula, whether it is exactly subretinal or it is pre-retinal. The only way you will know is sometimes you press and you see a reflex, that means you've not yet gone. The other indication is that if you see this kind of thing, it's obviously not gone into subretinal space. And if you see a displacement, you see a blanching around the tip, that is blood is displaced. It is still not at subretinal. It is there because blood is, it is pushing, then needle is pushing the blood away, that is why it's getting displaced. Once you actually enter into subretinal space, again it will come back to normal, like how it was for before, like this. So when you see a blanching, that means it is still not in the subretinal space. You have to go slightly advance further. And this is one of the first case of subretinal hemorrhage which I have done, is a one-eyed patient, retinitis pigmentosa with a subretinal hemorrhage. The reason we do not know, I could not find the cause even after displacement of blood. Yeah, this is one of the first cases. I have done it injected manually to the 1 ml syringe, but now currently we do visco VFI module from Constellation and as described. And one of the concerns that we see is that we do not want to have a blowout macular hole. That is a concern for us. So try to create a bleb at the inferior edge of the subretinal hemorrhage, at the inferior arcade, and try to create this bleb that goes inferiorly from the inferior arcade, so that the fluid, the subretinal TPA fluid doesn't come up and try to cause a blowout fracture, blowout macular hole which is there above. So once we see a good fluid wave, and you think this is a small hemorrhage, so at one place it's enough. Suppose you find a big subretinal hemorrhage, you may need to create 2-3 kind of blebs at different locations, and the maximum that we've discussed, we can inject up to 0.4 ml of this drug. Okay, this is how it is in the first postoperative. The plain air has been injected, and most of the vitreoretinal surgeons, once we inject subretinal TPA, we also want to do some slight modifications to basically increase the chance of displacement or displace it even further. The which is the most easiest modification, or which doesn't cost much, is subretinal injection of air along with the TPA. So there is logic for that, and this has been done in this study, where they studied whether along with the TPA, if the air is injected, what is how the experience of displacement of subretinal hemorrhage. They found that in this 24 eyes in this they studied, the displacement of subretinal hemorrhage is complete in 100% of cases. The only advantage which they propose is it gets displaced even beyond the arcades in 75% of this patient if subretinal air is also injected, and even more beyond equator up to 20%. But even we see that Dr. Dipender has shown that even with intravitreal gas alone, there are quite a few cases where it is displaced even beyond the arcades. And interestingly, in this particular study, they found that even sub-RP hemorrhage was displaced in 73.7% of the people. Only in 25% the subretinal hemorrhage, sub-RP hemorrhage could not be displaced. So this is a injection of subretinal air. Yeah, this is a case of post-traumatic hemorrhage, a 30-year-old male. And this is a second case that we've done. And then the studies of subretinal gene therapy injections also have shown that age is a factor. The younger the patient that is there, you will find that the amount of pressure that you need to do to inject the drug is slightly higher. So this particular patient is the first time I was trying with the viscous fluid injector and not hand. And a couple of places I had to change the location because I was not able to inject the drug, and it was some amount of reflex was happening. This amount of reflex of TPA is not a big concern, but there's a big concern if you are injecting subretinal gene therapy. We do not want this much reflex to happen, so because that will cause a lot of uveitis. So while injecting, you have to make sure that you don't do any lateral movement of the tip of the cannula, because that it may get enlarged. The microretinotomy that you're creating might get enlarged, and they can. The advantage which they say with the subretinal air is that it forms some sort of an airlock. At least you'll see that whatever TPA that is injected probably does not come out into the vitreous cavity. There's one advantage. And in this if you give a subretinal TPA, for the next day you can make the patient sit, and that because the buoyancy of the subretinal air itself, that will also help in pushing the hemorrhage down mechanically and probably displacing it further. So this is how this particular patient behaved after this displacement, but there is foveal thinning. And there's another interesting case of a young boy, a 16-year-old boy with some large subretinal hemorrhage and also some amount of localized retinal detachment. Apart from hemorrhage, there is fluid accumulation also, and there is a thick subretinal hemorrhage, and also there is an open, there's a macular hole that is there that is already developed. This particular patient, subretinal TPA was planned. Once you get into the subretinal space and you start injecting the TPA, you see that some amount of bleeding is already coming from the macular hole into the vitreous cavity. That was expected in this particular case because we know there is a macular hole, and once some amount of, nevertheless as per plan, we continued to inject a little bit more of drug, and then that was followed by a inverted ILM peeling, and then the surgery was closed. And of course he had a choroidal rupture. You can see the hemorrhage is displaced beyond arcades, and this is how the patient behaved post surgery. The other interesting case of a laser proliferative diabetic retinopathy has come with sudden decrease of vision. It is not pre-oil suboil, it is subretinal hemorrhage that has caused the sudden decrease in vision. She was taken off for surgery, and following removal of the membranes, which took about 20-25 minutes in this particular case, and then by the time you can see the subretinal hemorrhage that was placed to be injected. Somewhere all after this, the media became hazy, and there is a feathery PSC that is developed in this particular case, and the media, and it was not possible to see the retina in this particular case, and we were at crossroads what to be done with this patient. So I injected silicone oil in this patient, and post injection of the silicone oil, through the oil again, with the clarity was slightly better, and then the injection was done to achieve a bleb, a small dose, and the patient is done well post this. Yeah, this is the same patient. So the other minor modifications which I'll be speaking about, it'll take less than a minute. The theory is that if you remove the internal limiting membrane, the site where you want to inject. So this study has shown that if you remove a local ILM membrane and inject without actually penetrating the full thickness retina, the jet of the fluid injection itself can cause the drug to go inside the vitreous cavity. And probably this is worth trying. Probably the next case you can see, you can do local ILM peeling and place the needle tip on the retina and inject. The jet stream itself can cause enough micro retinotomy so that drug gets delivered and the bleb is created. The other change is nanovitretinal subretinal gateway device, which is nothing but a handle with extendable needle, 30 gauge needle it is attached, and the trocar, the 40 gauge cannula tip is extendable from the handle, and this is a non-vitrectomizing way of injecting subretinal TPA. You can use a chandelier. This particular study, so you can use a chandelier and with this 30 gauge needle directly go and inject the drug into the submacular space without doing a vitrectomy. So that subsequently when you want to give an anti-VEGF, you have enough vitreous and the half-life of the anti-VEGF is not disturbed. This is an interesting thing to do it, provided we have this device here. The other way is, if you're a beginner and you're not sure whether you want to visualize the bleb, whether it's actually going inside or no, you can do you can stain the drug TPA with a fluorescein strip, and then while injecting you can have a look the bleb that is being created, and be happy that it has reached the correct destination where it is intended to be. Improved visualization and also ability to review the influx. Thank you.